Welcome to ID Talk, answers from an infectious diseases expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and a leader at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. Today is Tuesday, July 14th. The COVID-19 situation in the nation is grim. We are well over 3.5 million cases that we know about of COVID-19 disease since the start of this pandemic, and nearly 140,000 deaths also that we know about. The current president has started to sideline the nation's expert in infectious diseases, Dr. Tony Fauci, and we are seeing continued political impact on a response to COVID-19 awareness and interventions throughout the country. On the plus side, there are 4 active vaccine research projects that are enrolling large numbers of patients. An additional another 90 to 100 vaccine products have been tested in phase 1 and phase 2 trials. The hope is to have an at least moderately successful vaccine product available and ready for release by January of 2021. Also, for those patients who are severely ill with COVID-19, there has been decent success in treatment and outcomes using dexamethasone as a cheap, affordable, high-potency steroid, and also the antiviral drug remdesivir. Additional drug discovery continues as we speak. To the member questions, and I urge all of you as you hear these responses to formulate and send further questions to keep this podcast active and vibrant to address your needs. The first set of questions has to do with when is it safe to assume a person, a child or an adult, who is diagnosed with COVID-19 could potentially be around high-risk individuals. Can they be around those individuals at all? And in a similar vein, how do we advise our families with school children or adolescents who want to work when those febrile children can return to school and to work? Well, the CDC response to this, which actually both incorporates known testing results as well as symptoms, is that an individual known to have a positive COVID-19 test needs to wait at least 10 days from that positive result and also be asymptomatic. Now, the asymptomatic period could be anywhere from at least 3 days to longer. And it could also be that patient has been asymptomatic the whole course. The key for this first requirement, though, is the time from the first positive test. Now, you will all ask, we'll talk about this a little bit later, what about the potential of continuing positive nasopharyngeal swabs because the PCR test detects RNA from the virus? That's true, that's very true, but that persistent positive does not factor into this definition of the time to remove oneself from self-quarantine. The other definition is that the patient be at least 72 hours from the resolution of fevers and also decrease in the respiratory symptoms, knowing that a patient with active respiratory symptoms will have persistence, shortness of breath, cough, wheeze, etc., well past the resolution of fever. So the key here is resolution of fever and the start of the resolution or diminution of the respiratory symptoms. That needs to have occurred at least 3 days prior to coming out of isolation and be at least 10 days from the onset of those symptoms. So again, key part here is 10 days from onset or 10 days from positive test and resolution of all symptoms or starting resolution for at least 3 days. Can children especially be around high-risk individuals, grandparents, immunocompromised people with those criteria? The evidence so far as we have right now, and it is not anywhere near complete, is that yes, they can. And that's good because especially younger children will be less adherent to wearing masks than perhaps older children with intent to try and protect their at-risk families, friends, etc., and so forth. As an additional note, emerging evidence is now suggesting that children, despite being the high carriers and high contagious individuals for influenza, are less known to be the transmitters and being the contagious individuals for COVID-19. In fact, population studies looking at families have found that children were far more likely to acquire the disease from their parents, not the other way around. So that doesn't mean that we can send the kids out carte blanche to school, to the playgrounds, to playgroup, to the pizza parlor. But it certainly suggests that using the CDC's definition of safety to remove self-quarantine should be adequate, at least for our kids, in terms of coming out of self-quarantine, going back to school, et cetera, and so forth. So, to the question about getting COVID-19 more than once, and also what about the persistence of positives? Well, this is difficult because the evidence as we currently know it suggests that patients who were asymptomatic with the COVID-19 infection or subsymptomatic or mild disease, meaning unaware they were sick at all or had low-grade fevers, etc., those individuals appear to have a less robust serologic response in terms of developing antibodies. In fact, very recent data just released yesterday, the 13th of July, suggested in two separate series that the length of detectable antibodies in a patient with mild or asymptomatic COVID-19 disease was no longer than 6 to 7 weeks. 6 to 7 weeks, whereas you would normally expect a robust IgG response for 6 to 7 months to years. So that's a concern. However, that does not correlate, at least not so far, with increased risk of getting the disease again. And in fact, those patients who are COVID-19 survivors do not seem to be originators of secondary cases, even if they are 6 to 7 weeks out and were asymptomatic at the start. And there do not appear to be secondary contacts related to those patients. So far as we know, the evidence would suggest that getting COVID-19 more than once is unlikely, despite the fact that nasopharyngeal swabs, which are molecular diagnostic based, so that the PCR, the nucleic acid amplification tests, those will continue to detect interval expression of the RNA of the virus in cells within the nasal epithelium which have been infected. That does not correlate to active contagious virus, and it does not necessarily correlate to a patient being contagious. All of that said, and I'm sorry, there's a whole bunch of ifs, ands, or buts because we still at a very early stage in understanding the kinetics of this virus. But if we use the experience we have with varicella, so chickenpox virus, and we look at all of us who have had to prove or demonstrate our immunity to varicella virus, yet we are still required to wear masks, N95 masks, and to observe airborne transmission requirements in hospitalized patients with primary varicella or even zoster, shingles. Why is that? Because the virus can still coat our nasal epithelium even if we're not reinfected with it and could still potentially be transmittable to an at-risk patient. That is a possibility, but of course it has not yet been tested because the focus on research has so far been on taking care of the actively infected patients. All right. What about testing? There are a lot of questions about testing very appropriately. What is the best timing after a COVID exposure to get tested? Well, the incubation period of the virus is anywhere from 2 to 14 days. On average, 4 to 5 days is the mean and the median incubation period. So a patient who was exposed, and you know when the exposure occurred, could reasonably be tested 72 hours out. So that's going to be prior to onset of any potential symptoms, and yet at a time when viral amplification is occurring within the nasopharynx and be testable or discoverable by a nasopharyngeal swab. So 72 hours after COVID exposure. What about the impact of pool testing in terms of providing a safe environment for our kids to return to school? Well, the pool testing, and for those who aren't familiar with the term, it means rather than running individual tests from every single individual that we test, we batch the specimens. So running 10 at a time or 50 at a time, which increases the throughput and decreases the time to get results. Now, of course, it means that if you have a positive in that batch, you don't know which of the 10 patients or 50 patients it was, but at least you can then start to go back and retest those individuals. Versus if you get a negative pooled result for all 10 or all 50 or however many kids, then you can clear those patients from being virally positive. So That is great. It's probably most impactful in terms of epidemiologic surveys and getting a sense of who and what excuse me, where are the densities of population infection. But in terms of clearing a population or clearing a pod of 10 or 50 kids to go back to school, it doesn't really have much meaning because they're still at risk to get COVID-19 the day after they're swabbed. And there is also the potential of a false negative. So that's a long way of saying I don't see a value in pool testing the kids for the express purpose of clearing them to open up the school system. However, in terms of epidemiologic surveys and trying to get a better handle on who is out there, who's infected, that has value. Of course, I would apply that to not just kids, but everybody to actually get a sense of what the true attack rate is. CDC released evidence this morning, as it turns out, confirming that at least 40% of COVID cases are asymptomatic and that the attack rate from those asymptomatic patients is much higher than the original 2 to 3% that was suspected. What about testing kids at all? Well, kids are likely to express higher levels of virus just because their immune systems are less robust. Doesn't mean they're any more contagious. As we talked about, they seem potentially to be less contagious in terms of causing secondary cases at home or potentially in the school district. So I think there is value in testing kids because they're as likely, if not more so, to be asymptomatic. Once again, it gets a sense of who is out there, where are the pools, how dense is the risk of COVID positivity. How long do patients remain PCR positive? One of our members had a patient who was positive in April when initially they were sick, and then again was positive in June when they returned for a fracture, for a broken leg. Yes, the assumption as expressed is that those were inactive viral particles. In fact, RNA of the SARS-CoV-2 virus being expressed in infected and diseased cells, which had probably already died, but were still present at the nasal epithelium and able to be sampled by the swab to express the RNA positivity. So, is there a carrier state? Not known. In fact, it's likely that after viral infection that the patients have a short course, whether it's 2 days or 14 days, but ultimately the active expression of virus which might be contagious, i.e. a carrier state, resolves, followed then by this intermittent positivity of PCR tests. So that's sort of like testing performance. The current tests out there, of course, which are available to ambulatory settings as well as hospitals, are the nasopharyngeal, the PCR tests, nucleic acid amplification, which can be rapid, antigen tests. There are several that are relatively sensitive and relatively specific, but not 100% at all. And then, of course, the serologic testing. A note about testing antibodies, that has zero value in clinical diagnosis and prognosis for patients. It is simply effective as a tool to say who was infected, how great is the attack rate within our community. And to that end, of course, it's quite powerful. A member asks, will there be guidance from the AAP about in-office testing? The short answer, I believe, and this is my personal opinion, is that no. The AAP is going to defer to the Food and Drug Administration, which is the source of validation and approval for the assays out there. Also, choice of the many available products is going to be based both on quality and performance of the product, as well as cost and what sort of a deal can be given by the reps. So I also am not prepared, as I would imagine if you are, to give a hard and fast recommendation. I would encourage all of you considering looking at purchasing the test construct for your offices, urgent cares, hospitals, to look at the FDA record, look at the performance of the tests, and certainly go under the guidance, as we all do, that cheaper is not always better. That's about as far as one can go without knowing specific products to comment on. Okay, next, a whole range of questions about personal protective equipment, the PPE. Will the AAP offer PPE guidance for well and sick visits? The AAP, I guess, has, and it really has endorsed CDC recommendations. And I think most of us, at least in the individuals that I've talked to in community practice or hospital-based practice, are already following that. Basically, everyone is wearing a surgical or a loop mask all the time anyway, right? Leaving the house, we have the mask on. That's reasonable. The impact of those masks primarily is to prevent we, the wearers, from transmitting virus from ourselves to those around us. There is, however, for the hospital-based or the medical supply-based surgical loop masks, and here I'm referring to the blue ones, the yellow ones, etc., there is a 40 to 60% reduction in acquisition of virus from somebody else who expresses aerosol into our face. Great, wonderful, fantastic. But in terms of seeing patients who may be COVID positive, so here we're talking the child with symptoms, the child with fever that doesn't have a clear alternate explanation for that, then we need to be wearing the N95 or KN95, that the increased barrier mask to prevent aerosol transmission covered by the surgical loop mask. The reason for the covering is not to increase the performance of the N95s, but simply to protect them from becoming saturated with droplets which may be inspired through the airflow. And it prevents, or I should say provides for a longer lifespan of those N95s. An important question is, what about the face shields, the eye shields, the eye goggles? In my hospital, Tucson Medical Center, based on CDC recommendation, we are all required to wear goggles or a face shield if we are entering the room of a patient who may be a suspect COVID patient, a PUI, or have known disease. And that makes a lot of sense because the eyes, as a source of mucosal exposure to aerosol droplets, could be a potential entry point. Not demonstrated, not proven by the research, but also that's not been studied thoroughly. So my recommendation, to base it on the CDC and the AAP endorses this, is to wear eye protection for sick visits in children and or any patient in whom there's a suspicion of or evaluation for COVID-19. The surgical loop masks 100% of the time, the N95 masks along with gowns, gloves, face shield for entering the room or exposing oneself to a suspect COVID patient. I guess on the other hand, sort of the opposite corollary of that is, do we need to wear the N95 masks and the eye shields and the gowns and the gloves for well visits, for giving vaccinations? And the answer is no. Knowing that, of course, there are going to be asymptomatic but infected children out there, but as I said before, their risk of transmitting disease to family, to adult care providers, to physicians is thought to be much lower than that of adult patients. So in a way, pediatrics is lucky. For once, we're not the ones who are dealing with the pools of pestilence, but in fact, we have a little bit of luxury to not wear the N95s every single visit. What about office room turnover, and especially the waiting rooms? That's a concern, of course. Yes, we all wish to socially distance, but what about the clinic room where a febrile child is evaluated for COVID-19, or just febrile child, period, for whatever reason? We don't know the COVID-19 results or not. How long does that room need to remain empty after the child has been there? Well, this really depends on what mechanism your clinic or your hospital employs for cleaning the room. So what we do in practice here, and I think it's a reasonable approach, is to do a terminal clean of that room. So wiping down the horizontal surfaces, any toys in the room, certainly the medical instruments like otoscope, ophthalmoscope, the chairs, exam table, etc., wiping all those down with the 10% bleach or the quaternary ammonia products or the whatever product that your office is using. And then the key there is to let the product dry for the dwell time that's listed on its label. Most products simply need a dry time of 4 minutes up to maybe 15 minutes. Our practice is to let the room air out after the wiping for 30 minutes. So yeah, that increases the time that a room is out of commission. And most clinics that I've talked to in our practice here as well is to split the clinic day into clean and dirty. And it sounds horrible to use the dirty for patients who might be COVID positive, but you know what I mean, right? So seeing the well visits, the vaccine visits, etc., first part of the day, and then reserving the second part of the day for the sick visits, the febrile kids, etc. Okay, so sort of launching then into those febrile kids as we go further into the summer, certainly into next winter, as we enter other respiratory virus seasons, certainly the related otitis media, streptococcal pharyngitis, etc., patients presenting to us without a clear fever source. So the hot ear, the kid who has the very painful sore throat. The other febrile children without that clear fever source do need to be considered patients under investigation for COVID-19. That's absolutely casting a wide net. It's going to include a whole bunch of kids who simply have rhinovirus, influenza, other enteroviruses, adeno, et cetera, and so forth. But for our safety and for the appropriate management of these patients, that's how we need to approach it. So I don't know if AAP will come out with recommendations on that. Certainly the section on infectious diseases supports that having a very low threshold and a high index of suspicion for COVID-19 disease in all febrile patients in the pediatric age range is safe and practical. A couple questions about specific management, especially our patients who have asthma or who come in with a wheezing and respiratory illness, a worry. Can we or can we not use the nebulizer machines, the SVN machines, knowing that there is a degree of aerosol generation? Well, yeah, that's true. And it would make sense if it is possible to designate one room in the office, or certainly one room in urgent care or the emergency department as the SVN room, and then apply the same terminal clean protocol after the patients are done there. We have to assume that there is at least some degree of aerosol generation which escapes the face mask with the patients as they use the machines. Yes, that's true. How effectively those patients are able to transmit COVID-19 if they're infected is not known. The studies would suggest that the risk is moderate but not extreme. Extreme risk would be intubating a patient, doing bronchoscopy, anything which induces a cough without any sort of protection. Here, yeah, the kids are likely coughing with the nebulized medication, but it's at least behind the oxygen mask, and there's some degree of barrier there. Knowing, of course, that the albuterol or whatever we're using is going to sort of blossom outside through the air holes. So terminal clean afterwards, as I described before. Same thing with giving an MDI, because that's expressed forceful both exhalation before taking the inhalation with the MDI. So if it's possible to give the MDIs outside, that would be fabulous, right? But for those patients in the room, same practice. Try and preserve a dirty room or a asthma treatment room, and just be prepared to do terminal cleans with the wipe downs, then air the room for 30 minutes after the patient. Sort of finally, epidemiologic questions. It would be awesome to know from the states, the Arizona Department of Health Services epidemiologic data, what the breakdown is for patients less than age 20. I think we all have seen the media published data that breaks down the age groups up to age 20 and then from 20 to 40, etc. Unfortunately, that data has not been parsed out that we have access to. So all we have the ability to do is to sort of ask for those of our providers who are in hospital to get a sense. In general, so this is my take talking to my colleagues in the community, and certainly my experience with the pediatric emergency department here at a large community hospital and our hospital ward. My sense is that the attack rate for severe COVID disease requiring hospitalization is not high in kids. A majority of the children that we have either evaluated in the emergency department or hospitalized were hospitalized initially as fevers without origin in younger kids, or older patients, adolescents, age 14 to 19 now, in my experience, who did come into the emergency department with respiratory distress and then respiratory failure. Yes, we have had about one patient a week, an adolescent who required ICU hospitalization with severe respiratory distress, requiring high flow nasal cannula oxygen. None intubated yet. Several patients did require pressors. Most had a transient episode of acute kidney injury, pretty much as you would expect, multi-system disease. However, and certainly the last several patients were treated with a combination of dexamethasone and remdesivir, all walked out of the hospital and have been recovering at home and doing well. So our experience with kids, knock on wood, has largely been quite positive. Yes, there have been a few deaths in pediatric patients. The deaths that I'm aware of were in children who pre-existingly had medical conditions and had special needs. So the otherwise healthy kid who does get hospitalized is a rare event and is typically a ultimately happy, successful event as they go home. What about the MISCs, multiple or multi-system inflammatory syndrome in children, MIS-C? My experience, I've treated 5 suspect MISCI patients, 2 of which were confirmed. They have responded to the IVIG and aspirin. One of the patients who ended up actually testing COVID-19 negative, although we strongly suspect clinically that that patient was a true MISCI, that patient already had significant aneurysms of the left anterior descending coronary artery on presentation after 6 days of fever. But again, the admission rate or suspicion rate of children with MISCI is also quite rare. This is not a common event, thank heavens. Yes, I encourage all of us to be on the lookout for children with fever, evidence of inflammatory vasculitis. So rash, conjunctival injection, the mucosal erythema, certainly peripheral edema and erythema of the hands and feet, and patients in whom one is performing some degree of evaluation, so blood work, etc., with a strong suspicion of severe COVID disease, it is appropriate to also get the inflammatory markers, C-reactive protein, ESR, and even a ferritin or D-dimer, something like that. But again, although I wish for all of us to be aware of MISCI and certainly to keep an open mind and again a high index of suspicion for the possibility, but not to run out looking for MISCI patients around every corner. This is still, thankfully, a rare event. Patients that we have managed and evaluated, again, have all done quite well. So that is sort of almost 30 minutes of the first podcast. Again, please do send me your questions. Thank you for listening to the ID Talk. Arizona AAP members can submit questions for future episodes to this email address, covid@azaap.org. That's COVID@azaap.org. For more information and also resources related to COVID-19 specifically in Arizona, or even to learn how to become a member of the chapter, please visit azaap.org. So with that, I'll sign off for July 14th. I wish all of you safety, calmness, and serenity as best we can. Hang in there, folks.